So we're going to talk about trauma teamwork today. Many people have already talked about ATLS at this conference. I saw at least 5 different slides about how important ATLS is. I saw it presented by physicians. I saw it presented by nurses. And we've heard this story that in 1976, an orthopedic surgeon and his family crashed their airplane, and they were injured, and there was nobody to take care of them. And that push has changed trauma care worldwide. ATLS is the standard. We've talked about it. People have taken the course in the United States, here in Colombia, around the world. And it is amazing how much it has changed just in our lifetime. And the history, I don't want to go over it again and again, but the American College of Surgeons and ATLS is a perfect example, and it talks about the importance of teamwork again and again and again from ATLS. If you remember, this is when you took ATLS, and hopefully many have taken it, it's intended to allow one single doctor in a rural hospital to manage a trauma patient. Anybody here work in a rural hospital? How many nurses and doctors work in your hospital? If I came to the hospital after a car crash, how many people would be helping me? So 1 doctor and 3 nurses. Okay, some places 1 doctor, 1 nurse. So you still have that. There it's a small team, 1 doctor, 1 nurse. Other places, who works at a big, busy level 1 trauma center, right? I do. How many doctors, how many nurses? If you come in after a car crash, we might have 10 doctors, 10 nurses, everybody. And the team size varies. ATLS is really taught for that very small place. And that's why ATLS is so important, but it might be different at a bigger trauma center. It depends on the size of your team. But what do you do if you have more than 1 person? What do you do when it's not just 1 doctor, 1 nurse at that small rural hospital? How can we work better as a team? And this goes to this question of trauma resuscitation, the approach of a vertical versus horizontal resuscitation. So it doesn't mean how the patient presents. This is not horizontal because the patient is horizontal. This is not vertical because they're laying on their side or sitting up with a gunshot wound or sitting up with a gunshot wound to the airway and they're only surviving because they have to sit up. That's not what we mean about horizontal and vertical. I'm going to show you what we do mean. The trauma that we all learned in ATLS is a vertical approach. It's planned for limited personnel, 1 doctor, 1 nurse. That's kind of how it's taught. And you do everything sequentially. You do the primary survey and then the secondary survey. So what does that look like? It's a very slow slide. First, you start the primary survey. Then you go to the resuscitation phase. Then you move along here. So what happens? If the first thing, and we'll go back to just ATLS, airway, you find an airway problem, what do? You stop, you fix the airway, and then after the airway is done, then you go to B for breathing. Then you listen for breath sounds. You might put a chest tube in. This is, first I have to put in the right chest tube, and then I have to walk around and put in the second chest tube. That's the way it's taught. A slow process, potentially, if you have a small team. Keeps going, it keeps going, it keeps going. This is slow, step by step by step. You have to do 1 at a time because the same person has to do it all. But what if we change to this horizontal? We can compress it and do multiple things at one time because you have a team. Okay? So now we might have it, and you'll see what that looks like. The airway people can be doing 1 piece. The primary resuscitator can be doing something else. You have people to do procedures like IV access or central line or chest tube or monitors and pulse ox and everything. It can all happen simultaneously. And it's the trauma team model. So if you work at a big, busy, active trauma center, this is what it's like. Many team members, many simultaneous interventions. It looks chaotic. If you've never seen it before, when we have people come and watch in our trauma center, our trauma resuscitation room has a window. So they can watch from the window and see, and there's 12 people all doing all things at once. And the people who see it for the first time have no idea what's going on. But the people who do it every day, it's very controlled, although it looks chaotic. And the trauma team leader is going to be key. Here's a picture. This is an old picture. Many of us have a picture just like this. This is when I was a resident. It's a team. It's everyone doing their job at the same time for the trauma patient. So I trained in Philadelphia, and this is a quote from one of my old mentors. Trauma resuscitation is a team sport with high stakes. If the team loses, the patient dies. It is a team. It is not one person. None of what we do is one person. And it's important to have a goal as a team. You need to have a mission. What's the mission? The best outcome for the patient. What's our plan? You've practiced this. You've done this before. We were talking at break. You've simulated this. You've brought the sim man down into the trauma bay, and you've practiced this again and again and again. And we see, 2,000 trauma patients at our trauma hospital. And we have another hospital that sees another 2,000. Same way every time. Everyone has the organized roles, right? It's commitment to the system. It's capacity, it's ability, we have all the things ready to go, and it's trust. We get to know each other, right? So I work with emergency medicine doctors I've known for almost 20 years. Same thing with the nurses. You get to know them and you trust them, and they understand your skills. You understand what they can do as well. An important part is the trauma leader. And that person isn't necessarily at the head intubating or at the patient's side doing the physical exam. They often stand back, and I said this yesterday, stand back, watch, and control. If you get sucked in too close, you can't be looking at the whole picture. So I think that's very important. So you have to control yourself as a leader. You have to control the team. You have to control the environment. You have to have a plan, but also be flexible. And we're going to go through each of these steps. And most of my talk today is about the initial trauma team resuscitation. And we'll talk a little bit about some other pieces as well, but mostly the trauma resuscitation. So first, you have to think about yourself as an individual leader. Don't panic. Has anybody ever heard that if there's a cardiac arrest and you're there, the first thing to do is take your own pulse? Have people heard that before? Right? You need to make sure that you're ready. You don't want to panic. You don't want to be like this. Nobody will look at you as a good leader if you're panicking. Be systematic. You've learned this. You've learned ATLS. You know what you're supposed to do. You should lead with your voice, not yelling. Yelling doesn't usually help. You should proceed strong, calm, but you should also know your limits. And there's a bunch of different criteria on leadership. I like a few of these quotes. There's nothing more demoralizing than a leader who can't clearly articulate why we're doing what we're doing. Sometimes when residents will ask me, well, why do you do it this way? I will tell them, and you've heard me say this already, oh, there's an EAST guideline and the data says we should always do it this way. That's great. Other times you'll say, that's the way I learned and it seems to work. Okay, but you should be able to explain it. Not defending yourself, but just helping people to learn. They're asking because they want to learn. Confidence is contagious. If you can uplift your team and you can talk to them and say, okay, I'm going to help. Do you know how to put a chest tube in? I've done too. Okay, go ahead and start. If you need help, I'll help you. That confidence is contagious, but so is lack of confidence. This says, that's why I never walk in front. And there's many ways to take this of what to do. Sometimes the leader does, and this reminds me of many things. The first thing it reminds me of is stand back and let the team do what they're supposed to. Maybe not exactly the best way to take this. But the other thing to take back is sometimes you as the leader do have to stand in front and you do have to lead the team. Sometimes, dog sleds in the Arctic, the front dog is the leader. Sometimes the leader is in the back. So there's many ways to take this. Okay, so the team preparation. When does the team preparation happen? It happens because you've trained already ahead of time. You've trained for days, weeks, months, years. You've done simulation. You've taught all the residents ATLS, emergency medicine residents, surgery residents, orthopedics residents. The nurses have taken the ATCN course, the same idea. You've trained and you've done this before. You've done simulation. So all the preparation has been before. So now what happens? We get a page, it comes out and it says trauma alert, patient arriving in 10 minutes after a motor vehicle collision. So now you get your team together. You have your pre-assigned roles. You're going to do airway, you're going to do procedures, you're going to do primary survey, you're going to do meds, whatever that is. You assign those roles. It's really, really nice. Sometimes you get there and it's chaotic because the patient's already there, short transport. People know what their role is supposed to be. I always know my role. The emergency medicine team knows their role. The surgery residents know their role. The technologists, the nurses, everyone knows their role. And then I think preparation has to include resources. So you can't show up and not have the resources and not know where they are. So this is a picture. We've seen this many times before. And if you visit trauma centers, and I visit a lot of trauma centers, there'll be the patient comes in, there's an airway team, the primary assessor, and this is often emergency medicine, or it could be surgery. There's someone doing ready for procedures, intravenous access or chest tubes. There's a nurse that might be helping with IV access. We have technicians, and I don't know who does that here, who puts on the monitor, puts on the pulse oximeter, puts on some oxygen. Different places do it differently, but there's all these people around. There's someone recording so you know what's going on. There's a team leader who stands and watches and makes sure everything happens appropriately. And sometimes as the team leader, you need to go get involved, but it's nice to sit back and stand back and make sure you hear everything that's going on. We have our CAT scan tech. We have a chaplain who comes in case the family is there and someone can go talk to the family outside of the room, calm them down, talk to them, explain what's going on. There's a big team. I've been to trauma centers where where if the stretcher is here, there's little X on the floor and you're supposed to stand in your X because your job is to do, you're the airway today. You're this, you're that, and you stand in that box and there's a picture on the wall of who's doing what. So you're going to control the personnel. You're going to assign tasks. It's really hard. It's easy if I know. I walk down, I see Mustafa Saeed. He's not here today. I see Mustafa Saeed. I've known him for a long time and I know exactly what he can do. It's often hard if there's someone I don't recognize and I'll say, oh, you're doing the airway. And I have to ask, how many times have you intubated a patient? And you might say, oh, I've done 100 intubations. The last time I asked that question, they said, I've done 4. I said, okay. So I'm going to watch more closely. And great, you're going to try. And if there's any problem, your backup is this person who's an anesthesiologist who's done 10,000, right? And that's okay. It's a teaching hospital, but you have to know the capabilities of your team. Oh, you're an emergency medicine resident. What year? It matters. Are you an intern, brand new out of medical school, or are you a graduating 4th-year resident who can do it all? So I have a slide for each of the roles. I'm not going to go through every single thing that each person does because hopefully you know that. But the important person, we've talked about the leader. So what does your team do? There's the primary assessor. They're the ones who call out the airway's intact. They have bilateral breath sounds. They're going through and they're telling the whole team. Everyone else has to be quiet so everyone can hear what's going on. We all want to hear when they say there's no breath sounds on the right. You don't want to hear. You want the person to speak up loud enough. And sometimes I'll tap them on the shoulder and say, you know, that person can't hear. Everyone has to hear. There's the airway team. And the way we do that at Johns Hopkins is our emergency medicine physicians manage the airway. So we have a resident or we have a faculty member, they're on the airway and they're doing the airway while the primary surveyor is doing the other pieces. They're evaluating it. Can you open your mouth? Is there blood in the airway? All these other questions. They're the ones who are managing that simultaneously. The procedure person, this is when it's ready and the person says, no breath sounds on the right. I turn over and say, great, put in a chest tube. Have you done this before? Do you know how to do this? Do I have to watch you? Or are you my chief resident and I know you can do it and I can focus on something else? The nurses, we talked yesterday about the collaboration with nurses, and we have multiple nurses in the trauma bay that have different roles and they do things at different times. It might be in, and we talked about special training in nursing. It is absolutely critical. Monitors, intravenous access. Our nurses use ultrasound for peripheral IV access, right? Other places, they don't do that, but the nurses can do that. They're the ones who are giving the medications we're going to use for rapid sequence intubation. They're giving blood transfusions. They are setting up our rapid transfuser for massive transfusion protocol. The nurses are doing all of these things. The radiographers, they're taking our x-rays when we need them to. The recorder, it's absolutely important to find out what happened when. The patient came in at 1 o'clock and at 2 minutes after the blood pressure was this, and then these were the vital signs, et cetera. What interventions do we do? When did they get TXA? When did they get blood? When did they get intubated? Chaplain, social worker, deal with the family who might have been in the car with them or on the back of the motorcycle or saw this person get shot. You have to control the environment. It can get very, very busy. So sometimes you have to control the patient. There's patients who are sometimes not just laying still, calmly laying there, right? And it's hard to tell sometimes. We heard it earlier. Are they intoxicated? Are they brain injured? It's missing an A, typo. Are they brain injured? Are they just a mean person? Are they in shock? Are they hypoxic? Are they dying of shock? Sometimes it's very hard to tell, but you have to control that. The uncontrolled patient can very quickly lead to an uncontrolled team. And sometimes all you need to do is give them a little space. They don't want 5 people there watching all their clothes get cut off and being naked in front of 20 people in the room. Sometimes all you need to do is say, we're going to pull back, the patient's okay, we're going to have one person talk to them. Sometimes that's great. Sometimes that doesn't work. And what do you need to do? Rapid sequence intubation. And, you know, there are many reasons for rapid sequence intubation. We have an unofficial rule. This is not an official rule of 3 expletives. We call it the 3FU rule. So if you're yelling and screaming and cursing and hitting, you know what we're going to do? We're going to intubate you because it's not safe for you as the patient and it's not safe for the team. And then we'll go get a CAT scan and we'll make sure you don't have a brain injury. We make sure you don't have other things. And then your alcohol can wear off and we'll extubate you. But we need it to be safe. So control the patient. Control the crowd. I put a small list of people who might be involved in the trauma bay. We had a case recently within the past year where lots of police, Dr. Osgood. We had a case where there were it was a pregnant woman who was shot. We did a resuscitative thoracotomy and a perimortem C-section. You can imagine everybody, we needed help from lots of people, and everybody who wasn't helping also wanted to watch. So there's 50 people trying to pack in and look and see what's going on. Sometimes you have to say, like, if you're not actually taking care of the patient right now, I need you to leave. And I would be like, if I don't recognize your face, I'd be like, who are you? Get out. Like, I need the people who are here so I can have my emergency medicine doctor, it turns out the obstetrician I know very well. Great. I need those people and I need the extra people to go away. Control the noise. It's really hard when you want to hear what's going on as the leader and you need to hear and the recorder needs to hear. And there's people having a conversation here and there's people talking over here. Co-leaders are bad. I'll tell you, you want to listen to your team, but you don't want 2 different people. You want the team to look and know exactly who's in charge. You're in charge, right? Not who's in charge today. Co-leaders is difficult. Lots and lots of irrelevant conversations of things that we don't need to hear. Sometimes you need a reboot. It's just loud, it's chaotic, it's going crazy. And sometimes I'll just be like, everybody just be quiet I need to hear from the airway team. I very rarely yell. So when I yell in the trauma bay, it is, number one, it's uncommon. It's not like I'm just yelling all the time. So then it's like, oh, this is actually something important. So in that reboot really can work. I need quiet so we can hear from the airway or whatever we're going to do. It's sometimes very, very useful that way. So there's lots and lots and lots of technology. It's our job to control all of that. Lots of the technology, the equipment, and all the people that help do all these different things. It's the intubation equipment, it's the ultrasound, it's the intraosseous, it's the warmer. There's lots of moving parts and all the people who want to do their thing. So back to ATLS. ATLS is a great framework, absolutely important. There's no time to look stuff up. It's one of the things I like the best about trauma. You never know what you're going to see that day. You never know if it's going to be the day that you get someone with their hand cut off or a pregnant woman who was shot or what you're going to see. Okay. You're not looking things up. It's a different type of medicine. Communication is absolutely critical. You got to do stuff. You got to keep doing things. My brother is not in medicine, and we were talking about something a couple of years ago. And I was explaining some things, what we do. And somehow the quote came about of, I said, I can kill you by just standing still. Okay. Don't want to do that. So you want to be flexible. You have a plan, but you also need to be flexible. Listen to the patients, whether they're actually telling you things like, this is what happened, this hurts, I can't move my leg, or listen to their physiology, their anatomy, these other pieces. Listen to your team. Never be, I'm the boss and I know everything and I don't want to listen to anybody. That is not a good leader. Okay. You have to tell them what to do, but you also have to ask for their feedback. So for example, we're doing other things. We're doing a resuscitative thoracotomy. The patient, I'll say, okay, I think we've tried everything. We've done this and this and this. Now's your chance. Am I missing anything? Is there anything else you want to do? Because otherwise we're going to terminate the resuscitation. And you wait. Did you hear how long it was awkward, how long I stopped? You have to wait to give people a chance. You can't say, okay, we've done everything. We've tried all these different things. I can't think of anything else to do. So I think we're going to call this and terminate the resuscitation unless anybody has anything to say. Okay, great. The patient is dead and the time of death is such and such. You have to give them time to speak. You have to actually be willing to listen. So sometimes you miss things. Dr. Osgood told a story. He's like, I missed this case. He's a really good orthopedic surgeon. We should all learn from that. Sometimes we miss things because we couldn't hear it. Sometimes we didn't think about it. Oh, that's a great idea. Oh, I didn't realize we hadn't started this medication or these other things. Listen to your team. They're going to tell you those things. So that's the trauma bay. That's how we can cooperate in the trauma bay. There's lots of other things we do throughout the hospital. So I'm a general surgeon. I'm a trauma surgeon. I do acute care surgery. I showed you a lot of my cases. I love to operate all over the whole entire body. Okay. But I don't do it all. And I will gladly ask for help from people who have more expertise than me. And I put up a list of all the surgeons that I've personally asked to operate and help me with things. And I've asked people who, I've been at Hopkins now almost 20 years. I asked people that I've known since they were an intern, they were a resident, they were a trainee, they went away for training and came back. I've asked them now for help because they're younger than me, but they have a specific expertise. Gunshot wound to the common bile duct right at the bifurcation. I do all the control. I get it all done. The patient is sick. And when they need a reconstruction, I called Matt Weiss. I said, you want to know why? He does this 150 times a year because he does hepatobiliary surgery. And I would do it every 2 years. And what's better for the patient? The better for the patient is Matt Weiss to do that. Okay. So ask the surgeons. I told the story to someone else about a partial nephrectomy, not a very common operation for trauma. Call the urologists, have them come and help you. And tell the story. John Cameron is our previous chair of surgery at Johns Hopkins. I would say he's potentially one of the most famous living surgeons in the world. His son is a transplant surgeon. He's about my age. And John Cameron used to call his son, who's a transplant surgeon, to help him, right? That shows you don't have ego. You're doing the best thing for your patient, having to call your son. I think it's kind of cool. I think it'd be fun to operate with my dad. There's lots of other physicians we collaborate with as well, right? So this is just a small list. Think of all the times, and we've talked about it at this meeting. How many people have talked about, surgeons in emergency medicine, or radiologists, or interventional radiology, psychiatry, we've talked about all these different things, right? Oh, we had GI medicine do an endoscopic retrograde cholangiogram, right? ERCP. Critical care is not on there. I'm sorry. You want to know why? I'm already critical care. I wasn't thinking about it. So we do our own critical care, but you're absolutely right. I apologize. See, my teammate corrected me. I made a mistake. And as soon as I saw you, I was like, oh no, maybe you won't notice. Okay, but there's lots of people we will work with. And I think there's lots of other team members who are not physicians. I put nurses here first. The question came up yesterday. Absolutely, we work with nurses. And we have multidisciplinary rounds. We talked about nurses in the trauma bay, but nurses, radiology, physical therapy, occupational, every kind of therapist you can think of, social worker, pharmacy, all these different people, we can't do it ourselves. It really takes a team, both in the trauma bay and throughout the whole rest of the trauma hospital. I stole some slides from some of my friends over the past few days. And here's some examples. So Dr. Fickey told us yesterday about mangled extremities, right? So here's his slide. It says, basically, oh, look, I work as a team, right? Teamwork, expert opinions. You're very senior, experienced orthopedic trauma surgeon, asks for help from vascular surgery, plastic surgery, senior partners, okay? Really important. When considering a primary amputation, always consider getting a second surgeon's opinion. Think as a team. Dr. Fickey has way more experience in this than me, and he would ask either me or one of his ortho or plastics. We have the team. Get the team experience. Dr. Osgood, okay? Patient-specific plan was developed. This is the early appropriate care protocol, was developed by all team members. All team members. It wasn't just the orthopedic surgeons who said, we're going to do this thing. And we already heard about it. Anesthesia, critical care, general surgery, etc. Teamwork, teamwork, teamwork. His slide as well. Implementing early appropriate care requires collaboration at all levels. Okay. Also happens in Spanish. Okay. Right? Trauma team, right? Equipo is team, right? Trauma team, teamwork. I was listening. I'm not the only one. Here's the structure of the team. And we talked the other day, I was talking with someone about being a cog in the wheel. That cog, this thing doesn't work when this one little piece is missing. So if you take off this one person, that's not going to work. And you need every person to make it happen. So these are not my slides. I took some other people's slides. So I have one or two more stories about teamwork and collaboration. I'm a member of the board of directors of CENTER. It's the Coalition for National Trauma Research. It's an organization in the United States that's 100% focused on trauma research to improve the care of trauma patients. We have members from many, many different surgical specialties, trauma nurses, et cetera. And we work together collaboratively for one mission, which is trauma research. And it can't just be me and my small group of trauma surgeons. We have anesthesiologists, orthopedic surgeons, nurses, neurosurgeons, et cetera, et cetera. Through that group, I have a funded research project, and we're doing implementation science to improve blood clot prevention in trauma patients. Well, we're out of order. I'm going to come back to that in a second. Oh, no, hold on. There you go. This is what I was looking for. So this group, these are the stakeholders in that group. We collaborate on this implementation science project to improve care for trauma patients. So we have the this is all within center. So this is about blood clots. So we've got a blood clot group, another blood clot group, a patient safety group, nurses, the American Trauma Society, which is a patient advocacy organization, as well as a bunch of different organizations that are related to trauma. Working together, working collaboratively is really, really important. So I know we're a little out of order. After the discussion yesterday, I went back, I was like, I know a ton of nurses. I work with so many of these nurses. So I decided I'm going to put together a picture of some of my nurses that I can't live without. So Suzette has been one of our nurse practitioners for 10 years. She's worked with me, like literally, here's my office, here's her desk, every single day that we're in clinic together. Deb Hobson, she does venous thromboembolism prevention with me. We've been working on blood clot prevention for 16 years. Okay. This is a bunch of nurses in the ICU. These are some of the nurses for more blood clot prevention. This is one of the emergency medicine nurses. I'm sorry, Mustafa's not here. She's worked with me for a very long time. The best compliment a surgeon can ever get is for a nurse to say, I need surgery. Would you do my surgery? You guys have had this, right? A nurse who works with you, or, you know, someone who comes to you and say, I trust you. I've seen you at work and I want you to do your surgery. She's allowed me to tell her story. She had a big incisional hernia. Absolutely critical. And then this might be one of my favorite pictures. So we were talking about Stop the Bleed, and I saw a really nice post. Oh my gosh, she went home early. I saw a very nice post about Stop the Bleed being done in Cali. You'll have to tell her I asked for her, Juliana. So this is me and my son. We were teaching Stop the Bleed to school nurses. Every single one of these women is a school nurse for one of the schools in the area around Baltimore. So we went out to the nurses, taught all those nurses how to do Stop the Bleed. They went to their schools, they bought some equipment, and we have then gone out in the meantime back to some of those schools and helped them teach larger classes to their faculty, to their staff, to their students. So I think it's important to, you know, work with all these trauma nurses. We talked about Society of Trauma Nurses yesterday. Someone brought it up. Who brought it up? I forget who brought it up. She's not here today either. Darn it. So this is me. I went to the Society of Trauma Nurses meeting. This is Sarah Maddox. Sarah was the president at the time. She had invited me to come and give a talk. I literally said, hey, Sarah, can we take a picture? And I turned around on the podium in front, and the two of us, we took a selfie in front of the audience. So you can collaborate, absolutely critical. So I've got one last piece in 2 minutes. So I mentioned venous thromboembolism. If you're interested in venous thromboembolism and trauma, here's a website. We put on a conference last spring. We had 50 participants in person. We had about 100 more online, and it was invited, and we talked about blood clot prevention. What should we do? What can we do? How can we do it better? You can go to this website. You can watch all the videos for free. You can download all of our slides for free, and you can hear about the conference. So why am I telling you about the conference? Well, number one, I want you to go learn more about blood clot prevention and trauma, and it's free. Did I mention that? That's one reason. So the other reason that we didn't talk about who else to partner with is patients. So I chaired that conference with trauma surgeon Todd Costantini from California, and we invited a patient. A patient came to the conference, spoke, and gave the patient perspective. She spoke for 20 minutes, just like everybody else had a 20-minute lecture. The patient had a 20-minute lecture on the patient experience. Have people seen that at a conference? Dr. Ficke, you and I were at the Patient Reported Outcomes Conference. We saw that. It's critically important to partner with the patient. So I just wanted to say, like, that's why I show this. This is the whole group: trauma surgeon, orthopedic surgeon, pharmacists, nurses, and I'm looking for Leslie. She's in here somewhere. You'll just have to trust me, she was there. So she was there. She was at the meeting. We have to partner with our patients. They're such a critically important part of the team. A lot of people have already mentioned it, and that's kind of what I wanted to end on. So I just put up some fun pictures of teamwork. Teamwork is critical. I think we all do much better. The patient does much better if we work well as a team. So thank you.